Right, just welcome everybody to Benton Health District meeting. Just giving you a heads up, we don't have a quorum today, so we won't be making any action on any action items, but we will be giving out information and stuff. So do we want to move on to public comment? If there's anybody here, I can make public comment.
And if you're online, you can raise your hand in the Zoom app, or you can press *9 to raise your hand if you're on a phone.
At this point, I'll adjourn the meeting. Thank you.
All right, thanks, Rocky. Yeah, Commissioner Mullen just heads up. He is pulling away from the meeting because he's still in another meeting. So
we are out and online now. So we're
you are. Oh, so you're sticking around then. Okay, great.
Well, we're going to be by Zoom, both myself and Commissioner Ditter's logging on right now.
Oh, great. So we will have a quorum then. Okay, thank you.
Perfect.
We'll keep going public comment, and then we'll go back to the meeting minutes approvals once those two get on.
And I'm not seeing any requests for comment online.
Okay. All right, so we will close public comment. Do you want us to do a staff report then? Or is Rocky still there? Is Clint popped in there now? I guess we got 5.
We got 5 now.
Yeah, so we can do that. Let's get going then. Okay. So can we get approval of June 6th special board meeting minutes?
They have a quorum with you and I.
Yeah, I'm not on yet. I can't get on there. They won't let me on.
So I move to approve June 6th special board meeting minutes.
And I'll second those.
Okay, a motion and a second. All in favor, say aye. Aye.
That's the meeting ID and that's the password.
I gotta get.
I'm assuming Rocky, you gave us a thumbs up too. Rocky, just confirming you're saying aye on the approval of the June 6th minutes.
Yes, I'm in approval.
All right, thank you. Let's move on to June 26th.
I do approve the June 26th, 2024, or I move to approve June 26th, 2024 regular board meeting minutes.
Okay, a motion and a second. All in favor, say aye. Aye.
Aye.
Any opposed? All right, thank you. Okay, so we already asked for public comment. We didn't get anybody online, correct? Okay, let's move on to senior staff comments. Nothing? Okay. Any unfinished business? None. Let's go on new business. Dr. Krager or Heather. Dr. Krager's on.
Hi, it's Dr. Krager, interim health officer. I don't know if I usually do the new business, but I am happy to do my little report, which I have a couple things to talk about. Let me share my screen. Oh, I do have some slides if I'm able to share my screen. There's a couple of topics I wanted to touch on today. Hope you all are doing well, staying cool. Let me try again. Okay, it's still saying host disabled participant screen sharing. Is there a way? I'm gonna give it a minute. If not, I'll just start talking.
We're working on it.
Okay, thanks.
Try again, Dr. Krager.
Try one more time if you can, Doctor.
Okay. Let's see. Great, thank you. Okay, hopefully you can see my slides. Great.
Yes, we can.
I don't think I can go into, present mode, but that's okay. Hopefully you can see it good enough.
Yeah, thank you.
I'll just make it bigger. There we go. Okay. So one of the things that I'm kind of passionate about and like talking about as well is learning about and I think is a really important piece of work in public health is tuberculosis. So most people hear about tuberculosis and they're like, oh, that was, consumption and we got rid of that like 50 years ago. And but it's actually still a pretty big problem. It's mostly, outside of the United States, I would say, but we still see tuberculosis in the United States. We still see tuberculosis in Washington, and we still see it in Benton-Franklin counties. It is thankfully pretty rare, but we do have to deal with it on a pretty regular basis. One thing I would also add is that of all the infectious diseases across the planet, TB usually is the #1 cause of death. The #1 killer across the world is tuberculosis, higher than HIV, higher than malaria. it still causes a lot of disease across the world. I'm going to talk a little bit about kind of where it ends up. And then I want to also just talk about kind of, what we do in public health to address tuberculosis. And just briefly touch on the difference between active and latent TB. Okay. I don't know if this is animating, but I found this little animation, which is kind of gross, but also interesting, generally how we transmit tuberculosis. So tuberculosis is a germ, bacterium. It's called, the full name is Mycobacterium tuberculosis. So most of the time, if someone's going to have what's called active tuberculosis, where they're like actively sick, is kind of how I think about it. It's in their lungs, and so how we spread it is, by someone speaking, coughing, singing, any way to kind of expel those bacteria from our lungs. And then if someone's nearby, and especially for like a long period of time, and breathe in those germs, that's how people get infected with tuberculosis. There is a much more common form of tuberculosis called inactive TB or latent TB. And that's where someone gets infected through their lungs, but then their body ends up kind of like fighting it off. It doesn't progress to an active infection, but it's still in their body. We can test for that with a blood test and sometimes like a skin test you may have had for some sort of work that you may have to do, but it doesn't test for active tuberculosis. We are concerned about latent TB in public health. We encourage people to get treated if they have latent TB because it can prevent activation later. But most of the work that we do at the public health department is around active tuberculosis, so people that are able to infect other people, which is why it's a public health issue, right? Where that's kind of the things we're most concerned about is something that can be spread to someone else. So we get involved in these active cases, and I'll talk more about kind of the work that we do around them. Let's see. Okay. So I wish this slide had slightly like darker colors. I kind of want, so this is, so epidemiology is like, how much of something is in a certain area, right? Or among a certain group. Incidence is a rate when we talk about tuberculosis. So we're talking about per 100,000 people each year, how many cases of active tuberculosis are we seeing? And I just want to kind of highlight some of the biggest discrepancies. So 0 to 9.9, you'll see the US is that lightest color. So that means per 100,000 people, and you'll see the actual number soon, we are less than 10 cases. Some places across the world have as many as 500 per 100,000. So, we're talking about rates that are 100, 200 times what we may see in the US. It's just a lot. There are countries that have really high burdens of tuberculosis. You'll see some countries in South America have higher rates. Some countries in Africa certainly have higher rates. Southeast Asia, Russia, Eastern Europe. Those are kind of the places with the highest burden of TB. Honestly, there's lots of reasons for why this, but probably the biggest one is just access to medical care. TB is extremely difficult to treat, takes a long time, it takes a lot of medications, it takes a coordinated healthcare system, and countries that kind of lack some of those resources have a harder time treating tuberculosis. So I'm going to narrow down to Washington, and we'll talk about Benton-Franklin briefly. We get about, we've been hovering kind of around 200 cases in Washington state over the last, decade or so. You can just look at this bar graph, 200 in 2014, a little over 200, 221 in 2023. We had a slight bump in 2022, but that seems to have gone down. We've been pretty flat, although our rate has gone down because our population has gotten a little bit bigger. So, and I'll show that in the next slide. This is just to show like the counties that have had tuberculosis cases are colored, and then the ones that have had more than 10 are this darker blue. So blanking on the name of that county, but mostly it's Snohomish, King, and Pierce. County are where the bulk of our TB cases, but lots of other counties across the state get tuberculosis. I previously worked at Clark County, and there were years where we had more than 10 cases, but it wasn't in 2023. Okay, let's see. Okay, I like this one. It only goes through 2021, but it does show just the nice trend that we've been seeing in the US of lower tuberculosis rates, which is great. We've kind of gone down, although over the last 20, 30 years, Washington is this green line, the United States rate is this red line. Washington used to be quite a bit lower, about half of what the United States rate was. We're basically similar now, but again, very low rates, especially when compared with other parts of the country, or sorry, other parts of the world. There are states with higher rates, but there's not a huge difference. Okay, that's enough number. This is my last slide on numbers. So I just looked at the last 5 years of cases. We see we have more cases in Benton County, 2, 2, 1, 4, 3, 2 in 2019 in Franklin County, and 3 in 2023 in Franklin County. So again, not huge numbers, but the amount of work that goes into each case is a lot. So I'm going to talk about that right now. So what do we do when we get a tuberculosis patient? Again, most cases of active tuberculosis are in your lungs, not all of them. You can have tuberculosis basically in any part of your body. But we're most concerned about the ones in your lungs because they can spread to other people. So, we work very, personally, I work with, providers. If someone has concern about an active TB case, like how do we, potentially diagnose that person? How do we rule them out and say, hey, this is not tuberculosis, this is something else? We work a lot with providers doing that. And then if we do identify active tuberculosis, getting that person on treatment as quickly as possible. That can involve coordinating medications. Generally, we start people on 4 different antibiotics. That goes down over time in most cases, but it's a lot. We're talking about people taking, 15, 20 pills a day. And so there's a lot that goes into that. One of the biggest reasons why tuberculosis is so difficult to treat is that standard of care, and the best way to treat it is using something called directly observed therapy, or DOT. That means every time someone takes a dose of medications, they're watched by a healthcare provider or a community health worker. Often in Washington, that's a public health nurse, but not always. And it sounds kind of funny, like we have to watch every single time, but the problem is we're treating for often 6 to 9 months at a time. People start to feel better, and then they stop taking their medications. And that leads to drug-resistant tuberculosis, and then people, don't completely treat their tuberculosis and it comes back. So all sorts of problems. When it's been compared, directly observed therapy with kind of other ways to do treatment, directly observed therapy is by far the best way to do it. We also do kind of monthly nursing assessments, just checking in with patients, seeing if they're having side effects, that sort of thing. People, we do struggle with adherence sometimes, and trying to come up with creative ways to help people stay on their medications, manage side effects. Maybe we'll take away a medication and use a different one. Maybe we can take one away and get away with it. It kind of just depends on their burden of disease and the other kind of details. One other point that I will make is that sometimes we're able to do video directly observed therapy, where we watch someone, over video. And that obviously is more convenient for the patients. Often it's often more convenient for us. But that is kind of just dependent on a case-by-case basis. A big part of our work is also a contact investigation. So anyone that may have been exposed, we're around someone with infectious tuberculosis, we try to gauge how much exposure they had and whether they need testing themselves. We're most concerned about kind of the most vulnerable, kids, people with immunosuppression, but pretty much anyone, especially if they had a lot of exposure to a person who was sick, we're going to do some sort of testing with them and then following up with them and potentially testing them again to make sure that they weren't infected. Then a lot of collaboration with providers. So picking the best TB regimen, looking at drug-drug interactions with their other medications. There's a lot of labs that, not always, but sometimes labs that need to be monitoring, chest x-rays, CAT scans, how long someone needs to be isolated from other people. That's something we work a lot on. That is kind of our response to tuberculosis. I have one other and kind of just a general kind of about TB. Like I said, I like talking about it. I think it's an interesting kind of problem that we deal with, and that's the end of that. And then I have one other thing, but if there's any questions on tuberculosis, I'm going to pause for a second.
Questions?
I do. So what is our role like in terms of medication management? Do we actually provide, drugs for people who need it?
Yeah, that's a great question. It depends on county to county, actually. And in Benton-Franklin, we usually rely on our healthcare providers to like write that prescription, and then we fill it at a pharmacy. We'll often like pick it up for people because we want to package it and make sure that they're taking it correctly every day. But that's usually who is doing it. If someone is not able to like afford medications or they don't have insurance, then sometimes we do step in and we're able to order medications from the state and provide them that way.
Do we provide the shorter regimens, the 3-month regimens versus the 9-month regimens here? Because I know they're more expensive.
Yeah, that is a great question. There is a shorter regimen. Unfortunately, there's been a shortage of one of the drugs in that regimen, so not very many people are using it. It's also it's hard to describe. It's most of the time we're able to do 6 months, I will say. That is at least for active tuberculosis. Sometimes we extend it to 9, but 6 months is kind of our baseline. There is a shorter regimen, and honestly, I don't know of anyone that has used it across the state yet because there has been a shortage of rifapentine, I believe. So not yet, but if that becomes more available, we might look at that.
And I know I'm asking too many questions, but
Okay.
in treatment of latent TB, have we considered providing kind of screening and treatment?
Yeah, I'm gonna talk more with our team about that. And actually, if Juan or Angela are on, I also wanted to highlight Angela is our TB nurse. She is wonderful. I did want to give her the opportunity to answer questions if she wants to. I think it's going to depend kind of on resources within our clinics, whether we're able to do that. It would be great, but it's also kind of an added layer of complexity. So I'm not sure is my answer right now. But if Angela or Juan have anything else to add, I'll let them chime in.
Right, excuse me, sorry. Hi, I'm Angela, I'm the TB program nurse here. So we will do the clinical screening, which includes the TB test, a send for chest x-ray, and then of course, Dr. Kreger reviews all of the client's information, recommends treatment or not. And the ones that are recommended to have LTBI treatment, we refer them back to their primary care provider for treatment right now.
And what if they don't have a primary care provider or they don't have access to care?
So then I try to get them established with care in Miramar or Tri-City Community Health, which I've had a lot of success with, especially Tri-City Community Health. They're usually willing, they can get them in, try to get them set up for insurance. Even if they can't get them set up with insurance for whatever reason, they do order the 340B medications from the state, and I think if they had to pay out of pocket, it's been a few years since I've looked into this, but it was around like $4 for rifampin monthly. So it's not a huge cost for the client.
Those are good questions. Yeah, I didn't even think about those questions until you said it. I'm like, those are good ones. So
Yeah, I mean, again, this, as Dr. Krieger has mentioned, it's a matter of resource, but I suspect the burden of latent TB is a lot in this community because of the minorities. I can tell you, I'm a latent TB case, and I don't know where I got exposed, but I came from a country that has probably potential for exposure. And, unfortunately, I can afford the medication, but not too many people would be screened nor get treated. I just got a case in my clinic. Somebody came from India, converted positive TB, and he could not afford the medication.
wow.
And fortunately, he's not active, but he's latent. And so, to me, if this patient cannot afford the medication, where does he go from here?
Right.
And so, from a public health entity, you would think that we should be able, if they're cheap, we should be able to acquire those and provide them, right? Assuming the patient is reliable.
Yeah.
Now, fortunately, we have some other resources to go to, but I cannot guarantee that every patient will necessarily have a primary care physician or be in a primary, be associated with a primary care physician. So as a public entity, where does our role come in? Should we be able to do it through our clinics here, just like we do with, other disease, processes?
So for us, it's always at the provider of last resort, right? As Angela mentioned, we do our best we have health insurance navigators. We do our best to connect people with resources to help provide with health resources. We work with all of the pharmacy and larger pharmaceutical corporations that offer the coupons and the drug discount programs. And again, all of our partners, they know that is their role as a federally qualified community health center, right, is to provide resources to those folks. And so we work really closely with those partners before we try to bring them in and provide care here. So always as an option, as a last resort, that is our role, one of our 10 essential services.
All right, thank you.
Any other questions?
No, I think that's good. Thank you.
All right. Thank you, Dr. Krieger.
I'm sorry, well, just one last little plug.
Go ahead.
Before you all go. So during COVID, I was not here, but we had done regular meetings with people from the agricultural community, right? To kind of help guide them through very difficult situations. So we had some really great partnerships with people. This is something Heather would talk more about, but she's not able to be on today. So I'm taking over for her. As I've talked about before, we've been seeing highly pathogenic avian influenza across the country. We thankfully have not had any dairy herds infected in Washington State, and Idaho has. I will note, you may have heard that there were a few more infections in humans in Colorado, I believe, and that was actually from poultry. So it kind of continues to be around. Given that, we want to restart those partnership calls. So we've been kind of rebuilding, contact lists. I wanted to ask you all, the Board of Health, as well as just kind of notify the public, if anyone is interested in joining one of those calls, reach out to Heather Hill. I put her email there. And we're gonna start hopefully next month one of those calls. And again, what we want to do is be a resource to the community, and hopefully hopefully we won't have any of, especially the highly pathogenic avian influenza, but just in case, we want to be prepared. So we're going to restart those calls.
Thank you.
And Heather's email, if you can't read it, is heatherh@bfhd.wa.gov.
All right. Thank you.
Thank you.
All right. Thanks, Dr. Krieger. Is that it?
Yes, that's all for me. Thank you.
Perfect. Moving on to Lineage Logistics Fire Update. Ms. Aaron.
All right, I've got two quick updates on new business for you, Lineage. Just bringing a little bit about what we've done in the last month since we last met, and then a little bit of information on our on-site sewage rule update. So in terms of Lineage, right now we're continuing to offer free well water sampling for nearby residents that live near the Lineage facility. So people can continue to come to us. We did give out about 100 of those bottles a month ago, and we've only had about 8 come in. So I haven't had a whole lot of uptake, but offer's still out there if people want it. We did in the last few weeks make contact with a local disinfection contractor. So a contractor that is a certified operator that goes around and disinfects wells. So for those that have taken advantage of the well water sampling and had E. coli in their water, we have hired somebody to go disinfect for those residents, so they don't have that added burden of having to disinfect their well right now. So we're working with some residents very near to the facility on making sure they have clean water. Until they have their wells disinfected, we are providing bottled water for their families, their animals, and their livestock. We are right now working on, with our comms group, on getting some messaging out on offering some coverage for costs for residents who did have to relocate during the smoke event. So we realized that when we got our Department of Commerce grant executed, the day the grant was executed, the fire went out. So there were no more relocation needs in terms of smoke. But we were able in the last few weeks, thanks to some assistance from Benton County Emergency Management, to have some conversations with Department of Commerce and get them to agree that allowable costs could include people who did relocate and have appropriate documentation during that smoke event. So we will be working with our comms group to get more messaging out about that to the community. On our side, continuing to meet with groups of environmental experts from Department of Health, ecology, around both well water sampling and what it might look like to probably make an ask of Lineage to do a little bit of long-term environmental monitoring on that site. And then Amanda and our communications team did get a new FAQ up on the website today. So kind of an answer to those community questions that they sent in. The Findlay community sent in a long list of about 20 questions they would like answered. Ecology put their answers on, Department of Health did, and then we got ours up today. So you can check out our website on that. Any questions on Lineage?
So if you had to go back in time and have the perfect scope, look backwards in time, what would you have done differently?
Which time do you have? It is very much the nature, I think, of work that happens in my branch on an emergency basis, that you're usually building the plane as you fly it. One of the things that we do plan to do here coming up soon is an after action process to hopefully answer that question. I don't know that I would have a summarized answer for you right now. But we are planning on getting both internally a group to do an after action report, and then hopefully with other community partners like Benton County Fire, Benton Clean Air, and those who participated. And that can be something that I could bring that summary back to this group, if that would be.
Yeah, that would be great. I mean, I don't see that fires in general are going to be less, they're going to be more with global warming. And so it's more likely than not, we're going to face similar, not exactly same, but similar kind of scenarios. And it would be helpful to know what we would have done differently or to mitigate some of the concerns.
Yeah, in general, I would say the biggest challenge was most of our guidelines and guidance out there around fire is written for wildfire smoke, not for an industrial factory fire. So from our agency to ecology to DOH to everybody involved, we've all found there's maybe some more digging we need to do around, setting some new guidelines around these unique situations, because it is not unique to us, but this was definitely a record fire in duration, in scope and scale. And so that was probably the biggest challenge. But
do we know of any hospitalization because of respiratory problems because of that issue specifically?
We don't know. Dr. Person, who is now working with us as an epidemiologist, she did do some digging through Essence and through Rhino to see if we could look at any signals in the area, but the community is so small that we didn't have enough. There wasn't enough, a large enough sample size really to identify anything. I don't really have, Carla might have a little bit more information on the Rhino or the Casper survey that's going to happen. So we are doing what's called a Casper, which is a kind of community assessment rapid response needs survey. And it's kind of an epidemiological survey that will hopefully pull out some of those trends to identify whether just those general effects on the residents and needs that they may have had during the incident. But in terms of hospital data that we did pull, it didn't show any signals. Anything else to add to the Casper?
It's coming, and it will be direct. It's a Casper survey, the direct survey designated by the geography and how many people we need to get from each certain census block to have valid results. So the community will be self-selected, right? We'll send the information out and they can choose to respond. And it'll be a digital survey at this point. And if we need to go door knocking, we can do that too.
Yeah.
So it's only the community members who will be surveyed as opposed to the responders? I'm asking.
Yes.
because I've seen responders who did go to urgent care and have respiratory issues and come to us for meds and.
Yeah.
It's not how the Casper's designed. It's
Okay.
designed to based on address and geography and residence, but we can take that back to some of the state FEs and see what their input is.
Some of them live in the area too. So,
Well, there's that.
yeah,
Just like the fire chief, he lives.
Philbirds,
Yeah.
many birds with one live, so.
I think to answer your question too, like this is a hard lesson learned, obviously, with the size of it, and even for the county side. If this ever happens again, which I pray it doesn't, but I think it'll be handled differently and faster. You know, like even if it happens in Montana or Idaho, there's very seldom do these type of fires happen. And so I think there's a lot different fixes that'll happen next time if it does ever, something like this ever happens again. But yeah, it's been with you guys' response and getting on it and everything, and me 5 weeks into it and saying, why is the fire still going? And we dove into it. And because even like I probably said in the last meeting when I was out there handing out masks and filters and fans with everybody, talking to them, pretty much everybody out there agreed, understood that, yeah, we get it, that it takes, 3 to 4 weeks to put out because of the size and, the way the food was compacted and everything. But again, after the 5th or 6th week or 7th week, that's where like, Lineage, you guys need to work 24 hours instead of 12 hours. So I think it's, again, I'm glad your guys' questions too, because I think that's a big thing is helping those guys out and everything, or the Finley people out, especially. And so you guys have been really responsive, and I think
Yeah.
I think they're very grateful for what you guys have been doing too. So
Yeah, I think that's the challenge is that every partner involved has acted quickly in nature, but the response has still been long in duration. So that really is, and nobody's had a playbook. Fire department didn't have a playbook. We didn't have a playbook. Where typically there's a little bit of a playbook to go, here's how you approach these situations. And this was so unique, is what I'm finding from top to bottom in every aspect of the environmental issues, very unique. So we're working through that. And I think that a lot of the partners that we're involved with, ecology and Department of Health, have paid attention, is what I've noticed. They went, maybe we need to write more playbooks on things like this. So I do think that some good stuff will come out of it. It's hard to feel like we're the ones who had to experience it. But all the partners have been really good about just, working with the community, working with us to help work through it. So some more conversations probably coming here then about the long-term monitoring and what that looks like, because we have identified that it is likely not within the scope of it's not ever within our scope usually to do long-term environmental monitoring, and it may not be within ecology scope in this case. So it may be something where we need to county, us and partners need to bring and ask to Lineage to fund some of this longer-term environmental monitoring for the community, especially if they want to rebuild and there's going to be a SEPA process and a process to know whether or not this is, appropriate. So I may come back with some of that next month. All right, if there's no more questions.
Can I ask
or you
just
have
one real quick on the well water samples? Are people, like when you hand out the bottles, are they responsible to drive them over here to get them tested? Is that?
A little bit of both. The first rings, we had about 10 houses that butt up against the property. We sent staff out to collect just so we could be extra sure we collected in a clean sampling manner. And we did some advanced sampling. We did some PFAS and heavy metals there too. But as far as the coliform, we gave the bottles out with the lab slips somewhat pre-filled, and we just need them to fill it up from the tap and bring it in. Yeah. So we noticed there's a little bit of a barrier there. But our staff were kind of at capacity too, in terms of driving around and collecting.
So I just had a thought pop in my head when we had the board meeting last week. We had the presentation and talking about the wells being on average like 50 feet deep, whatever. I was completely shocked to hear that. You'd think it'd be 100 feet or 150 feet. If they're deep, if someone were deep like that, 100, 150 feet, would they still get contaminated even though the water's seeping through the ground? Doesn't that contamination stick in the ground versus going in the well water? If they're deep?
It's possible, but it is less likely. So it's more challenging for contaminants to travel that.
Exactly. Yeah.
Takes a long distance. for
Yeah.
them to
That's
travel.
when I heard the majority were 50 feet, I'm like, holy moly. So.
Yeah, that again, everything about this was complicated.
Yeah.
The soil type out there, the shallow wells, the shallow groundwater, the lack of modeling. We don't have hydrogeologic modeling. There's a lot wrapped up in it. But yeah, it would take much longer to travel that deep. Okay, All right, so quick, moving on to onsite sewage rule update. So some months ago, probably 4 or 5 months ago, Jody came and gave a presentation on the state's update of WAC 246272A, which is the onsite sewage rules, and that we have 1 year to update our local rules and regulations. So as once we get closer to having a draft, we'll probably bring those to you in bits and pieces, because ultimately we're going to come to the board to sign off on that rule. And so rather than dump it all on you at once, I want to bring, here's some where we're at now through the spring. We put together a public and industry survey. So every environmental health staff member and some other staff across the agency put a link to the survey in their email signature. We had them posted on our front office. We did website postings, social media postings, and we have a page where septic system installers have to go to book a final inspection, and we had a link to that right there. So the survey ran for 3.5 months. We got 36 responses. 7 of those had specific comments about the rule change. They actually made very specific comments about things they would like to see or don't want to see changed. 12 of those responses indicated they'd be willing to participate in an internal stakeholder work group, and 27 of those just wanted to be updated on the progress of the rule change. What we did was we took the summary of the specific public comments we received and we put it into a document that's now up on our webpage. And as we work through each of those comments in the industry or stakeholder work group, we will update our responses in terms of what our recommendation is on change rule, don't change rule, et cetera. So you can find that on our website. It's under our on-site sewage website. And then we've sent out, a couple of weeks ago, we sent out initial invites to people who indicated they would be interested in joining the stakeholder work group, and hoping to hold the first meeting in about 2 weeks. So we will put together a work group that's represented by multiple industries that are impacted by on-site sewage rules: installers, real estate, engineers, designers, community-based organizations, et cetera, and work through the draft of the rule and the public comments to make sure that we have kind of some consensus and support from industry on our recommendations. Questions?
Do you need a board member at that meeting too then, or not? Or is it mostly staff?
That is up to you all if you want. I know, Marcy, you were one of the people through the conservation role that was indicated willingness to participate. So whether you or a colleague participates, either one. So we may have a natural connection there, but if that's something that you all want to talk about, talking amongst yourself to send somebody else, that's up to you.
Anybody want to join, be a part of that, or just wait till we get a presentation?
I'm already tangentially involved, whether or not
Okay, so you're, okay, cool.
Efficient use of time here. But the invite's open.
I try to keep my tasks separate.
Yeah, I know.
We'll be, yeah.
Okay, all right, thank you.
All right, Mr. Kyle.
Hello, everyone. So I'm going to be asking for a 1.0 FTE for our office, or for the refugee health program. So BFHD was selected to receive funds from the Office of Refugee Resettlement to support connect to healthcare and services for health-related social needs. The funds will cover the associated costs of staffing and materials for a 1.0 FTE community health worker who will offer direct support to eligible clients to support resettlement and integration into the community. The position will be a budget neutral position, and the current proposal will be funded for 2 years. So if you guys have any questions on that, Carla here will be happy to answer them.
Is it something that this is going to last for 2 years, or is it going to be something 2 years from now we need to ask for more funding, or?
There's a potential. So the current budget proposal, the federal funds that we know about are a 2-year cycle, which isn't unusual for our grant funded programs. So we're not too concerned about that. This is actually a continuation of a grant that we had a staff person in that has been absorbed into other program work. So with natural attrition and turnover, we don't significantly have to say program's over, we're laying someone off. So that's our anticipation with this time around, but we don't know for sure. And what they have offered us right now is 2 full years of funding.
And you said budget neutral too, so you guys say that, I'm all for it, so. Any questions? we get a motion.
I do move to approve the Office of Refugee Resettlement Community Health Worker, 1.0 FTE.
Okay.
Got a motion and a second. There's any discussion? Hearing none, all in favor, say aye. Aye. Any opposed? Look for is Didier and they're still on.
I saw Mullen.
Didier was
I'm
still there.
You're still.
Okay, so we're
Yeah,
still.
they're both
okay,
there,
we still have a
yeah.
quorum.
I saw Mullen unmute briefly.
Okay, just making sure. Okay. Alrighty. Is that good? Oh, we got, announcements.
I do have one announcement before Aaron steps up here. We are going through our financial audit here at the Health District. They started in June. So the board members will be getting an invite to the entrance conference that will be happening next week.
So I just had a meeting last week with a gentleman.
Yes.
Is that where you're at? So basically he's doing this to all the board members?
No, I think he just talked to you and that was a risk assessment
Oh,
for the
gotcha.
agency.
Okay.
The entrance conference will be next week and they'll just talk about their objectives and what they're going to be looking at. And then once they're done with their audit, there'll be an exit interview where everybody will be pre-invited and then they'll talk about whatever they found during the audit. So
Gotcha.
just a heads up on that. Thanks, guys.
Thanks. Right, Ms. Aaron.
I'm back. Okay. Real quick announcement, just to add on, you may have seen a Tri-City Herald article a couple of days ago about FINS, which is Washington State Department of Health's new foodborne illness notification system. So DOH has rolled out this new system. It's an online survey to allow the public to self-report foodborne illnesses and food safety complaints. So we will be putting a link to that reporting survey on our website. It will direct people over to DOH's website. Consumers can use it to self-report concerns like illness symptoms, poor food handling, pests or rodents, sick workers, all the things that typically come directly to our staff. And we are still more than open and willing to have the public call us directly with these reports. This will not replace our process. It's just going to integrate within our process and just allow the public to do a little bit of legwork ahead of time to report anonymously a report on their own.
So when that is reported, does that come to us through that link or does it go to?
Yeah, so it goes into a statewide system and then you select which county you live in and that automatically a report gets sent to that county. So there are a few of us who are on that notification report and we'll get notification that the complaint has been received. And then we would integrate that into our own complaint system and follow up with the complainant.
Janae, go ahead, Janae, you got your hands raised. Your hand, singular, sorry.
I just have two announcements when Aaron's done there.
Okay.
Okay.
You need a question, Aaron? Okay, thank you. All right, Ms. Janae, go ahead.
All right, so two quick announcements for y'all. First of all, I wanted to say congratulations to our non-elected board members, Katie, Dr. Kwandi, and Marcy there, because you guys have been with us for a year now. And I think that it's fair to say that what we all have gone through here at BFHD, yourselves included, we didn't know. And I appreciate you all not running away and staying the course with us. And hopefully, knock on wood, this next year is a little bit quieter in some areas and a lot bigger in terms of the work of public health. So thank you all for taking this journey with us. My second announcement, which is a great segue, is I wanted to let the whole board know, or electeds and non-electeds, that we have WASALFO has a local board of health training coming up in October 1st through the 3rd. And it's in Leavenworth, which will be beautiful, and it would be paid for. So if you guys have the time and you're interested in learning more about from WASALFO, the role of the Board of Health in local public health, let me know and I'll coordinate getting you guys set up for that. So that's it. Thank you.
Thank you. All right. So let's move on to item 8, approval of vouchers. Could we get a motion on that one?
I move that the Board of Health approve payment of voucher numbers 49-2024 through 53-2024 in the amount of $1,342,617.68.
I second that.
A motion and a second. Any discussion? Hearing none, all in favor say aye. Aye. Any opposed? All right. Before we adjourn, is there any comments or anything, questions, anyone from the staff or other business? We're good? Okay. Let's take the rest of the day off. Next board meeting is August 21st. This meeting is adjourned.